Welcome to the Deep Dive. Today we're taking a deep plunge into a topic that's often really misunderstood, but impacts so many lives. Avoidant Restrictive Food Intake Disorder. You might hear it called ARFID.
Mm-hmm.
And you might think of it as just extreme picky eating, but, well, it's so much more than that. It can lead to some pretty significant challenges for individuals and, their families too.
Absolutely.
So our mission today really is to unpack what ARFID actually is, what's the latest research telling us, and crucially, what practical, actionable steps can you actually take to support someone who's dealing with it.
Right.
We've looked at a really comprehensive parent guide and some key research studies to kind of distill the essential insights for you.
And I think for many of you listening, this deep dive might just provide that clarity you've been looking for. It could put a name to behaviors you've seen or really struggled with yourself for years. Those aha moments.
Yeah, exactly. Hopefully making things click.
Mm-hmm.
Okay, so let's get into it. ARFID, what is it at its core?
Well, fundamentally, it's an eating disorder.
Mhm.
But it shows up as maybe highly selective eating, sometimes a real lack of interest in food altogether, or this intense fear about negative consequences from eating.
Like what kind of consequences?
Things like choking or vomiting, maybe even having an allergic reaction, real tangible fears.
Got it. And the impact of that. It's not trivial.
Oh, not at all.
Yeah.
The consequences can be really significant. We're talking actual nutritional deficiencies, sometimes noticeable weight loss, or particularly in kids, a failure to gain weight as they should.
Wow.
Yeah, and in more severe cases, it might even mean needing supplements or even tube feeding to get enough nutrition.
That sounds serious.
It is, and beyond the physical side, it really interferes with daily life, social situations, school, work, just overall psychosocial functioning.
Okay, so how is it formally defined, like in
Well,
the DSM-5?
Right, so the DSM-5, the diagnostic manual, it outlines the specific criteria, but the absolute critical thing to understand, and this is often that big aha moment for people,
Right.
it's that ARFID is not driven by concerns about body weight or shape. There's no distress about being fat or a drive for thinness.
Okay, wait, that's huge.
It is. It's a fundamental difference from eating disorders like anorexia or bulimia nervosa.
So that point about body image, or rather the lack of it being the driver, why is that so revolutionary for people to grasp? What does knowing that change?
Well, it changes everything, really. It means you're not looking at interventions focused on body dissatisfaction or societal pressures about appearance.
Right.
Instead, you realize the root cause might be sensory overload or deep-seated anxiety, maybe even past trauma related to eating. So the focus shifts entirely. It's about function, safety, managing fear, not about weight goals.
That makes so much sense. It reframes the whole problem.
Exactly. Families might have been pushing the wrong buttons, so to speak, trying to address body image when that wasn't the issue at all.
Okay, so given that crucial distinction, how does ARFID actually look?
Yeah.
How does it manifest day to day? Are there common patterns?
Yeah, absolutely. The sources we looked at point to sort of three common ways it presents.
Okay.
First, there's what we call sensory-based avoidance. This is where the person reacts really strongly to the sensory properties of food, the texture, the smell, maybe even just how it looks.
Like, I can't eat that, it's slimy, or it smells weird.
Precisely. Things feeling wrong in the mouth or the smell being overwhelming. Then the second type is fear-based avoidance.
Okay.
This comes from a genuine, often intense fear of those adverse consequences we mentioned, choking, vomiting, having a bad reaction, maybe based on a past negative experience.
Right, a real fear response.
Exactly. And the third presentation is characterized by just a persistent low appetite or a general lack of interest in eating. It's almost like food isn't reinforcing or hunger cues are weak. They just don't seem interested.
Those three really cover a lot of ground. I
Yeah.
can definitely see how listeners might be nodding along, recognizing one or more of those patterns. The texture thing, the fear, or just that baffling lack of interest in food. It helps to categorize it.
Mm-hmm. It gives shape to the problem.
Definitely. So understanding how it shows up is one piece, but who is typically affected by ARFID?
Mm-hmm.
And how common is it?
Really? Well, the research, like the Fisher study from 2014, shows it often starts in childhood. That's quite common. But it's definitely not just a childhood thing. It can persist right into adolescence and adulthood.
Okay, so it's not something people necessarily just grow out of.
Not always, no. And it affects both males and females. What's also really important is that it frequently co-occurs with other conditions,
Like what?
particularly anxiety disorders, that's a big one, also autism spectrum disorder and sensory processing disorders. Seeing ARFID alongside these is quite common.
Right, so it's often part of a bigger picture.
Exactly. And that comorbidity, having these other conditions present, really influences how ARFID looks and, importantly, how it needs to be treated.
So that brings us to the underlying causes. This is where it gets really interesting, I think. What does the research, like the Kambana study, tell us about why this happens? What's driving it underneath?
Well, it reinforces that link with anxiety and neurodevelopmental disorders. They are very commonly found in individuals with ARFID.
Okay.
And digging a bit deeper, many children with ARFID seem to have specific sensory sensitivities, maybe hypersensitive to tastes, textures, smells, or they might have had a past traumatic or aversive experience related to eating.
Like what sort of experience?
It could be anything from severe nausea or reflux that made eating unpleasant, or maybe a frightening choking incident in the past, something that created a really strong negative association.
So if you're listening, maybe you're a parent or you care for someone with these struggles,
Mhm.
realizing this isn't just stubbornness, right? It's not a behavioral choice in that simple sense.
Absolutely not.
It could be deep anxiety or their sensory world being overwhelming or a past event that's still echoing. That understanding must completely change how you approach training to help.
It has to. It shifts you from frustration, maybe, to empathy and a search for the right kind of support. It's fundamental.
Yeah, okay. So speaking of support then, what about treatment? Is there a well-supported approach? What does the evidence suggest works best for ARFID?
Yes, thankfully there is. The most evidence-based treatment model right now is cognitive behavioral therapy specifically adapted for ARFID, so CBT-AR.
CBT-AR, okay. What does that involve?
It's a structured approach, drawing from work by researchers like Thomas and colleagues. It usually has several key parts. First, there's psychoeducation.
Just understanding the disorder.
Exactly. Helping the individual and their family really get what ARFID is, why it happens, what maintains it. Then a big component is food exposure.
Ah, trying new foods, which sounds scary.
It can be, which is why it's done using hierarchies. Very gradual, systematic steps. Not just throwing them in the deep end, it's carefully planned.
Okay, that makes sense. Gradual exposure. What else?
Anxiety management is crucial because trying new foods is often anxiety-provoking for someone with ARFID. So teaching coping skills, relaxation techniques, ways to manage that distress is key.
Right, giving them tools.
Mm-hmm. Or finally, especially for kids and teens, parent training is often a cornerstone. Equipping parents or caregivers with specific strategies to support the process at home consistently.
That sounds really comprehensive, like a roadmap.
It is. It offers a structured way forward, which can bring a lot of hope when families have felt lost or stuck for a long time.
Absolutely. That structure itself feels like a relief.
Yeah.
So, building on that hope, I imagine the biggest question for many listeners right now is probably, okay, what can I do? What are the practical things parents or caregivers can start doing at home?
Yes, this is often where people really want the concrete advice. And the parent guide we looked at lays out 6 really key strategies. They're very actionable.
Okay, let's hear them. Strategy number 1.
Number 1, and maybe the most important starting point, validate and understand. Acknowledge the child's distress. Your instinct might be to say, oh, just try it, or it's not scary, or it's yummy.
Yeah, the quick reassurance.
Right, but that can feel minimizing to them. Their fear or discomfort is real for them. So instead, try validating language. Things like, I can see this food feels really hard for you right now, or I know this seems scary or uncomfortable. I'm really proud of you for just sitting here with it.
That sounds so different, less confrontational.
Totally. It immediately reduces that power struggle dynamic. You're on their side.
Okay, great first step. What's number 2?
Number 2 is track foods and progress. Keep a list of the foods the person does eat their safe foods, but also, critically, track the small wins with new foods.
Small wins like...
What? Like even just tolerating it on the plate.
Right.
Or touching it, smelling it, maybe licking it. These are all steps before eating. Celebrate those tiny bits of progress.
Acknowledging the steps, not just the final bite.
Exactly. It shows progress is happening. Okay, number 3. Use gentle food exposure.
We touched on this with CBT-AR. How does it look at home?
Very low pressure, very stepwise. Maybe the first step is just seeing the new food across the table, then having it on their plate, but maybe far away, then closer, then maybe touching it with a fork, then a finger, then smelling it, then maybe a tiny lick or nibble, then eventually a bite.
So breaking it down into micro steps.
Yes. And the absolute key is that each step should feel manageable to the person, not forced. And you praise the effort at each step. Wow, you touched the carrot. That's awesome.
Got it. Low pressure, praise effort. Number 4.
Number 4, collaborate with a treatment team. This is so important. ARFID is complex. Look for professionals trained specifically in CBT-AR if possible.
Where do you find those people?
You'd look for therapists, dietitians, maybe occupational therapists who have experience with eating disorders, yes, but also potentially sensory processing issues, anxiety, maybe autism if that's relevant. It often takes a team approach. Don't try to go it completely alone.
Right. Get expert help. Makes sense. Number 5.
Number 5 is learn regulation and coping tools. Since anxiety is often a huge part of ARFID, teaching the person, especially kids, ways to calm their nervous system is incredibly helpful. Things they can do before or during stressful meal times.
Like what kind of tools?
Deep breathing is a classic. Smell the flower, blow out the candle is a good kid-friendly cue. Grounding exercises like the 5, 4, 3, 2, 1 census technique. Name 5 things you see, 4 things you feel, etc. Even visualization, like pretending to be a brave food explorer on an adventure.
Giving them ways to manage the anxiety surge.
Exactly. It gives them some agency. And finally, number 6, use praise over pressure.
Okay, we've talked about praise, but emphasize this one more.
Yeah, it's about praising every single step of the effort, not just the outcome of eating. So instead of focusing only on did you eat it, praise things like, thanks for letting that new food sit on your plate today. That showed real bravery. Or, I noticed you smelled the broccoli. That's a fantastic step.
So it reinforces the trying, the engagement, not just consumption.
Precisely. It keeps the motivation going without adding pressure, which often backfires with ARFID.
Those 6 strategies feel really solid and practical.
Mm-hmm.
Are there any other sort of supporting skills or approaches that help create the right environment?
Yeah, definitely. A few other things really round out the picture. Positive reinforcement systems can work well for some like sticker charts or earning points for brave food exposures.
Okay.
Building really predictable routines around meals helps lower stress. Knowing what to expect can be calming.
Makes sense.
Modeling is powerful too. Let your child see you trying and enjoying a variety of foods, but without any expectation or pressure on them to do the same immediately, just normalizing it.
Just exposure through watching.
Right. And making family meals happen regularly, even if the person with ARFID eats different foods initially, helps increase that passive exposure and reduces feelings of isolation or shame.
Yeah, being part of the meal, even if eating differently.
Exactly. And underlying all of this, patience. Endless patience. Celebrating the absolute tiniest steps forward, those micro wins, and actively avoiding ultimatums, punishments, or force feeding, which only tend to increase anxiety and make things worse long term.
That's a lot of great practical advice.
Yeah.
So pulling this all together, we've really untacked ARFID today. It's clear it's this complex eating disorder, but also, importantly, manageable. It needs understanding, these specific kinds of strategies we've discussed, and often, yeah, professional support. But the big takeaway is, it is absolutely not just picky eating.
Not at all. And recognizing that difference is probably the most critical first step towards getting effective help.
So what's the final thought you want to leave our listeners with today? Something provocative, perhaps?
I think the biggest shift, the most provocative thought maybe, is this. Understanding ARFID truly allows you, forces you almost, to shift perspective. Away from frustration, away from judgment, towards real empathy. It's about seeing the behavior not as defiance, but as a manifestation of underlying challenges. Sensory overload, intense anxiety, past negative experiences. And when you grasp that, it empowers you. You approach food challenges not just with more compassion, but with actual clarity and effective strategies. You start seeing those tiny steps like smelling a new food, not as failure, but as the significant victories they truly are for someone navigating ARFID.
That's a powerful reframe. Shifting from frustration to empathy and recognizing the small wins.
Exactly. That knowledge changes everything.
Fantastic. For those of you wanting to dig even deeper or find sport communities, we really recommend checking out websites like feastedded.org, that's feast.org, also nationalleadingdisorders.org, and for UK listeners, arfidawarenessseek.org. Lots of great resources there.
Yeah, definitely good places to continue learning.